Welcome to the deep dive. Today we're really focusing in on irritable bowel syndrome, IBS.
IBS.
It's super common, isn't it? But maybe often misunderstood. So if you're looking to sort of nail down the key facts for revision, you are definitely in the right place.
Absolutely. We've basically gone through the revision notes to pull out all the crucial stuff.
Exactly. The mission here is a clear, high-yield understanding of IBS, covering all the essentials, without getting bogged down in unnecessary detail.
Think of it as your IDS revision booster. So where should we start? Maybe the definition.
Good idea. Okay, so IBS. At its heart, it's a really common functional gut disorder.
Functional meaning. No obvious physical damage.
Precisely. The main things are abdominal pain or discomfort that keeps coming back and changes in bowel habits. But crucially, doctors can't pinpoint a structural or biochemical cause.
Right. It used to be just called functional, but now the thinking is shifting more towards it being a disorder of the brain-gut interaction.
Like a communication problem between the brain and the gut.
Exactly. And it typically relapses and remits, so symptoms flare up, then settle down again.
That pain often seems linked to going to the toilet, doesn't it? Or changes in stool frequency or consistency.
Yes, often. And bloating or feeling distended is another really big feature for many people.
It can really mess with your quality of life, I imagine.
Oh, massively. Quality of life, social functioning. But it's important to reassure people, and this is key for revision. IBS doesn't lead to serious diseases like cancer, and it doesn't increase mortality.
That's a crucial point. Okay, so if it's this brain-gut communication issue, what actually causes it? The etiology.
Well, that's where it gets a bit complex. The short answer is we don't know the exact cause. It's definitely multifactorial.
Meaning lots of different things can contribute.
Exactly. Think of it like several pieces of a puzzle fitting together.
Okay, so what are the main pieces? What do the notes point to?
Well, first up, there's often abnormal gut motility. So the way the gut muscles move things along might be too fast or maybe too slow.
Right, diarrhea or constipation.
Then there's visceral hypersensitivity. Basically, the gut nerves are sort of extra sensitive. Normal gut activity might feel painful.
Ouch, okay.
That brain-gut axis we mentioned, definitely a key player. Disruptions in those signals going back and forth.
And what about things like stress?
Oh yeah, psychosocial factors like stress, anxiety, they can have a huge impact. And maybe even the autonomic nervous system, the body's automatic control system, is involved somehow.
Interesting. The notes also mention genetics, right? Like you might be more susceptible.
Yeah, there seems to be some genetic susceptibility, though it's not like one single IBS gene. It varies.
Yeah.
And that ties into the different subtypes too.
Yes, the subtypes. IBS-C for constipation, IBS-D for diarrhea.
And IBS-M for mixed or alternating.
Right. And even if someone has, say, slow transit on a test, it doesn't always perfectly match up with their main symptom being constipation, does it?
No, it doesn't always correlate directly, which again just highlights how complex it is. It's not just about motility.
What else is in the mix? Immune system, gut bacteria.
Increasingly, yes. There's growing evidence for the role of the immune system, maybe some low-grade inflammation or activation, and definitely changes in the gut microbiome, the balance of bacteria in your gut.
And infections can sometimes trigger it, can't they? Post-infectious IBS.
Absolutely.
Yeah.
A bout of gastroenteritis can sometimes kickstart IBS symptoms that persist. And even antibiotics, because they disrupt the gut bacteria, might play a role for some.
So it's this really intricate interplay of gut function, maybe some genetic predisposition, nerve sensitivity, the brain connection, immune factors.
Yeah, quite a web.
Okay, so bearing all that in mind, who tends to get IBS?
Yeah.
What are the key risk factors we should remember?
Well, the notes highlight a few things. It's significantly more common in women.
Okay.
Age is a factor, too. It usually develops in younger adults, say, under 50.
Right.
A history of GI infections, like we just mentioned, that post-infective group, that's a big one.
Makes sense.
Also, having other mental health conditions like anxiety or depression seems to increase the risk.
The brain-gut link again.
Definitely. And finally, a family history of IBS. If your close relatives have it, your chances are a bit higher.
Okay, that gives us a good picture of who's more at risk. And the pathophysiology, the what's going wrong bit, that really just reflects all those causes we talked about.
Pretty much, yes. It's that combination of abnormal motility, the visceral hypersensitivity, maybe some immune dysfunction or changes in the gut microbiota, and that faulty brain-gut communication. It's usually not one single mechanism, but several acting together.
Got it. Now, this is really important for clinical practice and exams, the differential diagnosis. If someone presents with these symptoms, what else could it be? What do we need to rule out?
Crucial point. You absolutely have to consider other conditions. Top of the list, especially with any red flags, would be things like colonic cancer
Okay, right, the serious stuff first.
and inflammatory bowel disease, so Crohn's disease and ulcerative colitis. They can look similar initially.
Okay, what else?
Bile acid malabsorption can cause chronic diarrhea, so that's on the list.
Mhm.
Coeliac disease, the intolerance to gluten, definitely needs testing for, especially with diarrhea or weight loss.
Makes sense.
Then you've got infections, maybe more persistent ones like giardiasis. Diverticular disease can cause pain and altered bowel habits.
Less common things too.
Yeah, though rare, you might consider gut neuroendocrine tumors like carcinoid, although they often have other symptoms too.
And thinking outside the gut itself.
Good point. Especially in women, you need to think about gynecological causes, pelvic inflammatory disease, maybe endometriosis, even ovarian tumors can sometimes cause abdominal pain.
And the psychological side.
Absolutely. As we said, anxiety, depression, somatization disorders, even panic attacks can manifest with significant gut symptoms or overlap with IBS. So it's a broad list to consider.
Definitely need to keep those differentials in mind. Okay, what about how common IBS actually is? Epidemiology.
It's really prevalent. Here in the UK, estimates are usually around 10 to 20% of the population.
Mhm.
That's potentially 1 in 5 people.
Wow, that's huge.
It is. And as we said, more common in women, typically starting in early adulthood.
Is it similar worldwide?
The prevalence varies quite a lot globally, actually.
Yeah.
Some studies show rates as low as 1%, others much higher, even up to 45%. But generally, that peak onset age seems to be around 20 to 30 years old.
Okay, so let's get down to the clinical features. What does IBS actually look like day to day for a patient? What are the core symptoms?
The absolute core features are that recurrent abdominal pain or discomfort, bloating, and those changes in bowel habit, diarrhea, constipation, or a mix.
And the intensity varies a lot.
Hugely, from mild annoyance for some to severely debilitating for others. And it can fluctuate a lot over time for the same person.
Are there specific criteria doctors use to help diagnose it, like the Rome criteria?
Yes, diagnostic criteria like the Rome criteria are often used. Generally, symptoms need to be present for at least 6 months before diagnosis. And the abdominal pain should have at least 2 of the following features. It's related to defecation, either improves or worsens. It's associated with a change in stool frequency, or it's associated with a change in stool form or appearance.
What about those other common symptoms? Bloating, mucus?
They are definitely very common supportive symptoms. Bloating and distension are major issues. Symptoms often worsen after eating. Passage of mucus per rectum is also quite typical.
Any other associated symptoms?
Yeah, people often report lethargy, feeling tired, nausea sometimes, backache, and even bladder symptoms like urgency or frequency.
Okay. And the notes mention some factors that make an IBS diagnosis more likely in someone presenting with symptoms.
Right, things like being younger, under 50, being female. A history of abuse, sadly, is a known association, having had a prior gut infection, and high levels of stress.
Are there scoring systems used, like the Manning criteria mentioned?
Yes, sometimes scoring systems like Manning or Rome are used formally. They essentially tally up characteristic symptoms to increase the diagnostic confidence. Think of them as helpful checklists.
But, and this is vital, we need to talk about red flags. Symptoms that mean it might not be IBS and needs urgent investigation.
Absolutely critical.
Yeah.
These are the warning signs for potentially serious underlying pathology, especially malignancy. Key ones are new onset of symptoms over the age of 50, or maybe 60 depending on guidelines.
Okay.
Unintentional and unexplained weight loss. Rectal bleeding, blood mixed in or on the stool. Iron deficiency anemia found on blood tests. And a fever.
The notes gave a mnemonic weight, right? Weight loss, elderly onset, intestinal bleeding, tests showing anemia inflammation.
That's a good one to remember.
What?
Weight loss, elderly onset 50 or 60, intestinal bleeding, tests like FBC for anemia, or raised inflammatory markers like CRP, fecal calprotectin.
So diagnosis really comes down to recognizing the typical symptom pattern, checking it fits the criteria, considering those likelihood factors, but most importantly, actively ruling out those red flags and other differentials.
Exactly. It's a clinical diagnosis primarily, made by careful history and examination, once organic disease has been reasonably excluded.
So given it's mainly clinical, what role do investigations actually play? Are tests needed?
That's a really key point for revision. You don't diagnose IBS with a test, but you use tests to rule out other things.
Right, excluding the mimics.
Precisely. Process of elimination. So some basic tests are usually recommended for anyone with suspected IBS symptoms.
Like what? What are the essentials?
A full blood count, FBC, to look for anemia. Inflammatory markers CRP and ESR are important because they're typically normal in IBS but raised in IBD.
Okay, FBC, CRP, ESR.
Fecal calprotectin is a really useful stool test now. It helps differentiate IBS from IBD quite effectively. Often avoids unnecessary endoscopies if it's low.
That's good. What else?
If diarrhea is prominent, you definitely do a Coeliac screen testing for anti-TTG or anti-endomycin antibodies.
Right. And maybe stool tests for infection if the history suggests it.
Yes, stool microscopy, culture, and sensitivity, especially if diarrhea is the main issue or if there's a history of recent travel or potential exposure.
The notes had another mnemonic here: CIA, Coeliac screen, inflammatory markers, anemia check.
CIA, yeah, that covers the main blood and stool tests for exclusion.
What about imaging or scopes?
Generally, not routine unless there are red flags or diagnostic uncertainty. For persistent bloating, sometimes a plain abdominal x-ray might be done, but it's often not that helpful.
And sigmoidoscopy or colonoscopy?
Flexible sigmoidoscopy might be considered in younger patients, say under 50 if there's uncertainty, perhaps to rule out distal colitis or polyps. But for older patients, especially over 50 or 60 with new symptoms or anyone with red flags like rectal bleeding, a full colonoscopy is usually the investigation of choice to view the entire colon.
Okay. Now, just as important as what's not usually needed, right? To avoid over-investigation.
Absolutely. Routine thyroid function tests not usually indicated unless other symptoms suggest thyroid issues. Routine abdominal ultrasound, generally low yield for IBS symptom. Routine colonoscopy or sigmoidoscopy in young patients with typical symptoms and no red flags, generally not needed. Routine fecal occult blood testing isn't recommended for diagnosis anymore.
Hydrogen breath tests.
Also not routinely recommended for IBS diagnosis itself, though they might be used later if specific issues like small intestinal bacterial overgrowth, SIBO, or lactose intolerance are suspected based on symptoms.
Maybe remember TRF, thyroid, ultrasound routine scopes, fecal occult blood routine. Tests to generally avoid initially.
TRF, yeah, that works. Avoid the unnecessary turf.
So when should referral happen beyond those initial tests?
Referral is mainly driven by red flags, diagnostic uncertainty, or failure to respond to primary care management.
So specifically?
Those red flags we listed: unintentional weight loss, rectal bleeding, especially over 50, strong family history of bowel or ovarian cancer, raised inflammatory markers like fecal calprotectin or CRP, or someone over 60 with a definite change in bowel habit for more than 6 weeks, particularly looser stools.
The FLO mnemonic, family history, losing weight, older onset, raised inflammatory markers, ongoing bleeding.
FLOW, yes. Those warrant further investigation, often via secondary care referral. And obviously, any suspicion of cancer based on symptoms triggers an urgent 2-week wait referral according to NICE guidelines.
What about referral for other reasons?
You might refer if lower bowel investigations like colonoscopy are needed to confirm or exclude diagnoses, or if upper GI symptoms are the main problem, maybe for a gastroscopy.
Gynecology referral if pelvic symptoms overlap.
Exactly, to rule out endometriosis or PID if suspected. And sometimes referral to psychological services is really helpful if the main issue becomes coping with persistent symptoms, even after medical treatment.
But the key is appropriate referral, avoiding unnecessary tests that can just heighten anxiety.
Precisely. Keep investigations focused.
Okay, let's pivot to management then. How do we actually help people with IBS feel better?
The main goal is symptom relief and improving that quality of life we talked about. It's often a stepwise approach.
Starting with lifestyle and diet.
Usually, yes. Non-prescription strategies first line. Simple lifestyle advice, managing stress is huge. So relaxation techniques, maybe mindfulness. Regular exercise is often beneficial too.
And diet. That seems key for many.
It really is. General healthy eating advice first. Regular meals, avoiding trigger foods if identified. Then adjusting fiber intake can help, sometimes more soluble fiber like asparagus for constipation, sometimes less insoluble fiber if it worsens bloating.
What about the low FODMAP diet? That gets mentioned a lot.
Yes, the low FODMAP diet is a specialist dietary approach that involves restricting certain types of carbohydrates that can be poorly absorbed and fermented in the gut. It can be very effective for some, particularly for bloating and diarrhea, but it's quite restrictive and ideally should be done with guidance from a dietitian.
Probiotics.
Probiotics are interesting. Some people find them helpful, but the evidence is a bit mixed, and it might depend on the specific strain and the person's symptoms. Worth trying one for maybe 4 weeks, see if it helps, but monitor.
So remember, SLDP, stress reduction, lifestyle like exercise, dietary changes, fiber, FODMAPs, Probiotics trial?
SLDP, yeah, covers those initial steps.
What if those aren't enough? What about medications?
Then we move to pharmacological treatments, usually targeted at the main symptom.
So for diarrhea,
Loperamide is the mainstay. It slows down gut transit. Use it as needed, or sometimes regularly if diarrhea is frequent.
pain and bloating.
Antispasmodics are often first choice. Things like mebeverine, hyoscine butyl bromide, or even peppermint oil capsules can help relax the gut muscle.
What if pain is more persistent?
If antispasmodics aren't cutting it, low-dose tricyclic antidepressants, like amitriptyline, can be very effective for visceral pain, even at doses much lower than used for depression.
Okay. And for constipation predominant IBS.
Laxatives are the way to go. Start with simple bulk-forming ones like aspagula, or osmotic laxatives like macrogol, polyethylene glycol, or lactulose. Stimulant laxatives like senna might be needed short-term sometimes.
You mentioned antidepressants for pain. Any others used?
Yes, SSRIs, selective serotonin reuptake inhibitors, like fluoxetine or citalopram, are sometimes used as second-line options for pain, or if there's coexisting anxiety or depression.
Any other drug classes? The notes mention antibiotics, 5-HT3 antagonists.
Right. Rifaximin, a poorly absorbed antibiotic, is sometimes used for bloating or IBS-D, thought to work by altering gut bacteria. 5-HT3 antagonists like ondansetron, usually used for nausea, or alastron, more restricted use, can sometimes help severe IBS-D by slowing transit and reducing sensitivity, but need careful monitoring.
And newer therapies.
There are newer agents like linaclotide or lubiprostone for IBS-C and luxetolene for IBS-D, but these are generally prescribed by specialists.
So mnemonic for drugs, Lapio, loperamide, antispasmodics, pain relief, antidepressants, antibiotics, rifaximin, agents for constipation, laxatives.
Alapier. That captures the main classes. Remember, treatment is often combined and tailored to the individual.
What about psychological therapies?
Really important, especially if symptoms persist despite medication, say after 12 months. Nice Creator recommends considering referral for therapies like cognitive behavioral therapy, CBT, hypnotherapy, or general psychological therapy.
How do they help?
They can help people develop coping strategies, change unhelpful thought patterns about their symptoms, manage stress better, and reduce the impact of IBS on their life. Hypnotherapy specifically targets gut-focused relaxation.
And finally, other therapies, acupuncture, reflexology.
These are sometimes explored by patients. The evidence base is generally quite limited compared to dietary, medical, and psychological approaches. Some herbal remedies might have potential, like peppermint oil, which is also an antispasmodic, but more research is needed for most.
Okay, comprehensive management strategy there. Lastly, what's the long-term outlook? Prognosis and complications.
Well, IBS is usually a chronic condition. Symptoms tend to fluctuate over time. They come and go.
Does it get better on its own?
For many, symptoms do persist long-term. The notes say over half still have symptoms after 7 years. A longer history sometimes makes improvement harder, and ongoing stress can definitely hinder recovery.
But crucially, no serious complications, no increased cancer risk.
Exactly. That's the key reassurance. IBS does not lead to IBD, colorectal cancer, or other serious organic bowel diseases. It doesn't shorten lifespan.
But it really impacts life.
Massively impacts quality of life, as we've said. It's strongly associated with psychological distress, anxiety, depression, and functional impairment in daily activities.
Is the prognosis different for the post-infective type?
There's some suggestion that the post-infective subgroup might have somewhat better prognosis, with symptoms potentially resolving in a significant number of people within maybe 5 or 6 years, but not always.
Okay. Any other potential sort of indirect complications?
While IBS itself isn't dangerous, the notes mention that people with IBS might have a slightly higher rate of certain surgeries, like cholecystectomy, gallbladder removal. This might be because heightened visceral sensitivity makes them more aware of abdominal pain, leading to more investigations that incidentally find things like gallstones. Not a direct complication of IBS, but an association seen sometimes.
So overall, chronic, fluctuating, impacts quality of life significantly, but fundamentally benign in terms of serious disease risk.
That's the bottom line. Manageable, but often persistent.
Okay, let's try and wrap this up for a revision then. Key takeaways for IBS.
It's common, defined by that abdominal pain and altered bowel habit combo, without structural pathology. Think brain-gut axis dysfunction.
Etiology is complex motility, sensitivity, microbiome, psych factors all play a role. Diagnosis relies on symptoms, criteria, and crucially, excluding red flags and differentials like IBD, Coeliac, cancer. Remember, weight and flow mnemonics for red flags referral.
Investigations like FBC, CRP, phacocalprotectin, Coeliac screen, remember CIA, are mainly for ruling out other conditions, not diagnosing IBS itself. Avoid unnecessary tests. TURF.
Management is stepwise. Lifestyle diet first, SLDP, then targeted medication, LAPA, loperamide, antispasmodic, scene modulators, laxatives, and psychological therapies if needed.
And prognosis. Chronic for many, big quality of life impact, but reassure patients it doesn't cause serious bowel disease or shorten life.
Excellent summary. Hopefully that gives you a really solid high-yield overview for your IBS revision.
Yeah, absolutely. And don't forget, for more resources, check out pastmsra.com and freemsra.com.
Definitely worth a look. One final thought to leave you with. We've talked a lot about the brain-gut axis, thinking beyond the usual diet and stress management, what everyday lifestyle factors, things people might easily overlook, could potentially influence that connection and impact IBS symptoms. Maybe something like sleep patterns or even the type and timing of physical activity. It's all connected, isn't it? Something to ponder.